All right, so continuing on with communication. So barriers to effective communication. Health professionals tend to work autonomous. Efforts to improve healthcare safety and quality are often jeopardized. So even though healthcare workers speak as being part of a team, they often work alone. How does this happen? When communication collaboration breakdown exists between healthcare workers, change and effort goes nowhere. Although every organization is unique, the barriers to communication that organizations face have common themes. Here are some common barriers. The barriers indicted can occur within disciplines, mostly between physician to physician, physician to nurse, nurse to nurse manager, with most of the barriers manifesting between nurses and physicians. Even though physicians and nurses interact numerous times throughout the day, they often have different perceptions in their roles and responsibilities to the patient needs, and thus different goals for the patient care. Cultural differences, different communication styles of different genders, hierarchies such as physicians at the top, role conflict, individuals at the bottom, or the hierarchy of problems. Speaking up can be really difficult. There's staff concerns of retaliation. How the relationship is between the individual affects how well the communication is. If physicians and nurses are having disagreements, delaying patient care can often happen, especially when nurses are reluctant or refuse to call the physician. Many of the communication issues listed have to do with different personality and communication styles. So let's discuss these communication styles. There's aggressive, passive, and assertive. Aggressive style. Communication skills. Closed-minded, poor listeners, can't see others' point of view, interrupts, monopolizes conversations. Beliefs. Everyone should be like me. I am never wrong. Characteristics. Achieve goals at others' expense. Bully, patronizing, and sarcastic. Behaviors. They put people down. They don't think they're wrong. They're bossy, overpowering, they're know-it-alls, and they won't show appreciation. Their feelings tend to be angry, hostile, frustrated, impatient. And nonverbal cues, you'll see a lot of pointing fingers, frowning, glaring, and loud tone with rigid posture. Verbal cues, you must, just do it, being verbally abusive. And problem-solving mechanisms tend to be argumentative and operate in a win-lose paradigm. Passive style is indirect, always agrees, doesn't speak up, hesitant, does the whole, well, I wish you would have done that, passive-aggressive beliefs, don't express true feelings, they don't make waves, they don't disagree, others have more rights, well, they're the doctor, they went to more schooling than you, they're very apologetic. They avoid conflict, ask permission, apologize too much, complain, and have difficulty implementing plans. They feel powerless, they wonder why they don't get credit, and they think others are better than them. So they fidget, they nod their head often and smile, no eye contact, low volume. Oops. Verbal cues are monotone, and their problem-solving mechanisms avoid and ignore the problem or withdraw from the situation. Assertive styles. So communication skills. Effective, active listener, states limits and sets expectations, does not judge, considers others' feelings and beliefs, believes all are valuable, handle all situations as best as possible, even if they do not win, all have rights and opinions. Characteristics, they're self-aware, they trust themselves and others, and open and flexible and proactive. Behaviors, they're fair, consistent, action-oriented. They're enthusiastic, even-tempered, and positive. Nonverbal cues are open, direct eye contact, relaxed, vocal volumes appropriate. They use I statements and they ask for options. They negotiate, bargain, trade, confront problems as they happen, and they don't let negative feelings build up. So when do we need aggressive style? Well, when a decision has to be made quickly during emergencies and you know you're right and the fact is crucial. So if you know you're right because you're going to order pizza from your pizza place, that's not crucial. But if you know you're right and the dose of epinephrine in order to resuscitate someone, you need to be aggressive. Passive, when the issue is minor. Remaining aware of your communication style and fine-tuning it as you're faced with different situations will help make you successful during times of conflict, which in turn will build trust. Understand the communication style of those you work with that will help you determine the best way to approach and work with them. When a problem caused by conflict are greater than the conflict itself, then be passive. When emotions are running high, let people gain perspective. When the other position is impossible to change for practical purpose, like a governmental policy. Effective communication has positive outcomes, improved information flow, and more effective intervention, improved safety, enhanced employee morale, increased patient and family satisfaction, and decreased length of stay and improved quality.
There's no doubt in my mind that clinicians care deeply about their patients and want to do their best by them. But what's surprising is our patients don't see our caring. They don't get our caring unless we give voice to it. So in this workshop, we talk about a model of patient-centered communication that ensures that patients feel heard, feel understood, and feel cared for. And a big part of the workshop is actually practicing these skills so that clinicians can leave the workshop with a specific set of behaviors they want to try the next time they're seeing patients.
Dr. Fortin's workshop has helped me communicate more.
I was on a surgical team when I noticed a doctor making a critical error. He was preparing to operate on the wrong side of a patient. Now, we have a surgical safety checklist that we follow, and in this case, we noticed the permit didn't match what the doctor was doing. So we tried to stop the surgeon, but he said the permit was wrong, even though it had been verified by the now sleeping patient. We couldn't even get support from the supervisor or the anesthesiologist. So in the end, the surgery went forward. As nurses, we felt awful because there was no support from management to stop this doctor. I mean, what's the point of having a checklist when it's not even followed? We felt absolutely powerless to be an advocate for this patient.
So, how do we stand up? How are we not powerless? Now, listen, not all interactions with physician or provider is going to be negative. It shouldn't be. I really hope that that's not the case. So here are some guidelines for nurses before communicating with a physician. Have I seen and assessed this patient myself before I call? So if you take a report for someone, they're like, she is all over the place. Do not call, make sure you assess the patient yourself. Do I have at hand the chart, list of current meds, IV fluid, and labs, most recent vital signs, lab work, date it was done,